In the mid 70s or so, I went to visit a friend of my boyhood friend, Rich Burris, who was a medical student. I think it was at Virginia. Anyway, I was at Pepperdine, and so I went back to see him. And it happened to be a time when he was going to see a brain surgery on a child. It was like a 2-year-old or something. And he said, "You want to go?" And I'm like, "They're not going to let me in, are they?" He goes, "Oh yeah, sure. You just get dressed up with all the stuff and all that, and you can just stand up on the sidelines." So I saw it, and I, like you, I just could not believe it. I didn't become a brain surgeon, but it was really impressive, and even more impressive now, I'm sure. I guess at that early age, the brain just bounces back much more readily than it would if I had that surgery at this point in my life.
Children's brains do recover more easily and more quickly than the adult brain, but we do adult surgery all the time. We can take out brain tumors deep in adult brains without doing any significant harm. So, neurosurgery has really evolved to the point where we can get anywhere, take out almost any tumor that we want to using techniques like, under the microscope and endoscopes, and we have lasers and robots that help us and computers, and it's really very sophisticated field at the moment. But although the child's brain does recover more quickly, it doesn't mean that we can't operate safely on adults.
Yeah, of course. But the idea there is that brain plasticity, that early on, brain areas that are damaged or extracted, other areas of the brain can take over those functions.
Yeah, there's a surgery we do, and I do it for epilepsy on children where literally entire half of their brain is having seizures and causing them to have seizures, which is really a firing of the neurons in the brain uncontrollably. And we do a surgery called a hemispherectomy, where we go in and remove an entire half of this child's brain. And if you do it before they're 6 years old, they can make essentially a full recovery. So, one half of the brain controls the contralateral arm and leg. One half of the brain is important for language. You can even take out the part of the brain that's important for language, and they will relearn language with the other side of their brain.
Hmm.
So they basically supercharge the plasticity of what brain they have left, allow that to control both arms and both legs, and become a whole human being with only half a brain.
That's interesting for the debate on blank slate versus to what extent genetics wires us to do things. I mean, there's a language instinct, as Steve Pinker famously wrote about with Broca's area, but I guess if it's early enough, there's a different part of the brain that can pick that up. That would seem to imply that it's a lot more malleable than like a genetically determined model would predict.
Yeah, there are great debates on plasticity as to whether the brain is really completely reprogramming itself, or whether the wiring is already there and either you use it or you don't use it.
Mm.
So the right side there are some patients and people who are right hemisphere dominant, who have language on the right side of their brains and not the left, although 99% of the population has it on the left. And there are parts of the right side of the brain that contribute to language. The musicality of our speech, what we call prosody, is on the other side of the brain than the part that mainly controls language. So what probably is there is that there is bilateral representation of the language circuitry, and you tend to use only one side, and then the brain wires itself to use that side. If that side is not there and you get there early enough, there is an ability to use it on the other side. So it doesn't mean that it's not genetically programmed there, because that probably is part of the baseline wiring, but it's latent, it's hidden, it's not used. And as you use different parts of the brain, then you strengthen those connections and they become stronger and stronger, and the ones you don't use become weaker and weaker.
Mm. Is it a myth, though, that, say, people who are blind have better hearing or something like that?
It's not a myth. There are people who are blind who can echolocate, who have the
Oh, wow.
abilities of a bat to click, make clicking sounds, hear the echoes, and essentially see the world around them, but not with vision. And they use parts of their brain that are in the visual cortex that they're not using. They also enhance their auditory cortex to do that. So there is a remarkable amount of plasticity, but some would argue that those abilities are latent within all of us, and we just don't use them. We don't access it. We don't strengthen that part of the brain that we could strengthen were we to not have vision and force ourselves to echolocate.
Oh, interesting. I'm going to have to rethink my discussion on what it's like to be a bat. My sense is you can't possibly know unless you are actually a bat. But I guess you could approximate it. or get
You
some
could,
sense.
but we have no sense of what it's like to be any other human being. I have a chapter that I humorously name "What is it like to be a brain,"
Yeah.
as a tribute to that Thomas Nagel paper that we all have read, that really asks the question of, what we don't really know what it is like to be anyone else. We don't know what it is like to experience anything, and the brain essentially creates the world around us. It's an active hallucination that is created as our senses come into our brain and give it information. And even our sense of self, who we are, is also to some extent an illusion or a hallucination, a story that's created by the brain that fools us into thinking that we have a certain amount of autonomy, that we have an identity that's stable over time, when we know our identity is not stable in any way, shape, or form, because our brain is constantly changing.
Yeah. Um, yeah. Okay. Well, we'll get into some of the philosophical stuff. I'm going to see if I can talk you into being a compatibilist instead of a determinist by the end of this discussion. Anyway, that's all really good stuff. But before we get into that, what's it like to be a brain surgeon? Take us from the beginning. Like, you're in med school, you have to specialize. You decide, okay, I'm going to go into neurosurgery. What all does that involve? Your book mostly discusses brain surgeries, but what about spinal cord stuff and the central
Yeah.
nervous system as a whole?
So most neurosurgeons do mostly spine surgery. If you take a cross section of all the neurosurgeons in the world, or in America even, 70% of the work is spine. Most of the community neurosurgeons do spine just because it's so much more common. And I trained to do spine surgery and take out spinal cord tumors and remove herniated discs. But there are some of us who specialize and just do brain surgery. And so during a residency, you learn how to do everything. So every neurosurgeon who comes out is comfortable in the spine and in the brain. You can then go on and do a fellowship and do extra training in one particular subspecialty. It could be vascular, so you're doing aneurysms and AVMs. It could be tumors. It could be epilepsy and movement disorder, Parkinson's disease. So there are lots of different areas of brain surgery, and the training is long and it's arduous. The average neurosurgery residency goes on for about 7 years after 4 years of medical school.
Whoa.
And then you add a fellowship in there. So most of us aren't done till we're in our early 30s. So when we first go out on my own, for example, I was 33 years old, which is sort of late in life. A lot of life has passed you by at that point before you hang your shingle and start your career.
Yeah, amazing. So, and what's it like the first time you open up a skull, or you open up the back and there's the spine and all that? It must just be like shocking.
Yeah, well, there's the first time you see it. There's the first time you assist it. There's the first time you do it on your own. When you're no longer a resident. But you've done so many cases, right? I mean, the residency training, you have to understand, we're exposing these students to thousands and thousands of operations that they've done, and they're doing more and more incrementally. When you start out your training, you're just doing a little bit. You're cutting the skin, maybe you're removing a little bone, supervised very, very carefully. And then there's some things that are just so risky and so challenging that some residents will never get to do them. There are certain moves that I'm not comfortable letting anyone else do but me, because that patient has entrusted me with their future and their destiny. And there are certain parts of it that are routine that I can oversee someone else doing and do it with them. But there are other parts of it where one wrong move and it's essentially game over for that patient. And that has to be my hand. I have to be the one doing that, because I have to live with the outcome as much as the patient has to live with the outcome. And I do talk a bit about the psychological burden of when things don't go perfectly. And, we're very good at what we do, and they very often go extremely well. But neurosurgery has inherent risks. And if you do enough of it, you're going to run into trouble. And sometimes that trouble is when you make a mistake, which is horrible. And sometimes that trouble is you could do everything perfectly, and the disease or the tumor or the aneurysm is just so difficult to treat that you're going to have a bad outcome no matter what you do. And that's equally burdensome to deal with, because you then have to go to the family and go to the patient, and express to them that things didn't go as well as you had hoped. And you have to live with that. And it affects every decision you make subsequently when things don't go perfectly, because we're achieving for a perfection that we can never fully achieve.
I think of you as like a professional athlete. So like tomorrow you have a neurosurgery, a brain surgery at 9 a.m. So it's like you're Djokovic and tomorrow's the final. Like, what do you do the night before? Do you go to bed early? No alcohol after 6? Or at what time do you get up? No coffee in the morning? What's your routine?
Yeah. I do not drink any alcohol during the week. I am in bed by 10 o'clock every night and usually asleep by 10:30. I wake up around 6 o'clock, 5:30, 6 o'clock. And I'm focused. I'm just going through my routine, same routine every morning. I'm thinking about the operation the night before, for sure. I'm planning it. I have a mental vision of what it's going to look like and what treacherous obstacles lie ahead that I need to overcome and how I'm going to deal with those. And I'm thinking about those moments. I'm thinking about the specific moments in the operation where I'm going to come across a certain vein that I know is stuck to the back of the tumor. And I'm thinking about it through the entire operation until I get there. And then I'm finally there. And then I have to deal with it, and I have to figure out what is my approach going to be. Maybe I thought I was going to do it one way and I get in there and see something that I didn't expect. And I have to make another decision and do it a different way. And it is very much like an athlete or, a mountain climber who's just very focused on what they're doing. But it's also a beautiful, mindful meditation where you're completely living in the moment. So at the moment when I'm operating like that, the outside world doesn't exist. My family doesn't exist for those moments. There's not an anxiety in my mind. I'm not worried about, health. I'm not worried about money. I'm not worried about anything but the physical task I'm trying to accomplish at that one moment in time. And in a way, it's a beautiful way to live, because you're totally present. And I love it. I love being in the operating room doing that.
Nice. It reminds me of Mihai Csikszentmihalyi's flow. So you're
It's
like an
completely
athlete.
flow.
Yeah.
Yeah, it's the ultimate flow state. I mean, not the ultimate. There's many flow states, but we do achieve a neurosurgical nirvana where we're in that state.
Mm. Yeah, and what you're doing it seems a little more delicate. I've had 2 hip replacements, for example. These are pretty mechanical, but I've also had 2 spine surgeries. I was always a little more nervous about that than the hip replacement. It's like, don't screw up in there. If you screw up the hip a little bit, it's here or there. But
yeah, I mean, the spinal cord, the diameter is really the diameter of your index finger. That's the cord, and it's surrounded by all this tough bone. And the surgeries are right next to that spinal cord. And there is always a risk that something could happen. And if it does, that's the control of your legs, it's the control of your bowels, the control of your bladder. I mean, it's everything going on below that level they're operating on.
Yeah. I had a tumor on my T12. Is that right there? Just above the, lower back, right? T12, right? When I was 19. Yeah, it developed slowly. This was like in high school. So 71, 72. I just had back pains, and my parents took me around to different doctors. They couldn't figure it out. So this is before CAT scans. I think they came online about 75 or something like that. I wore a back brace for a year because they thought somebody diagnosed me with scoliosis, which I had a little bit of. And I had this clear plastic front and back piece with wing nuts that held it together. It was really fun. I looked like I had a huge chest. It was great. But then I finally got that. But I was only 19. And my parents were way more worried than I was. I just like, well, whatever, I'll be fine.
I think you're immortal at that age.
Yeah, totally. But he got Dr. Kenneth Head at Perdue Hills Hospital. Yeah, he was great. But there were no consequences of that. So yeah, anyway.
It's wonderful.
Okay, so the other part about your book that I liked was the history. It's not that old of a science or medicine or whatever. It's astonishing how recent all this stuff is.
Only about 120 years. The first neurosurgeon who really dedicated his life just to neurosurgery was a guy named Harvey Cushing. And he's a legendary figure within the field. Not everybody has heard of him, which is remarkable to neurosurgeons and brain surgeons because he's so important to us. But he wrote the first paper sort of introducing the field in 1905. And that was really the day of our birth certificate of neurosurgery. And when he started operating, the mortality of brain surgery was about 50%. So half of the patients operated on would die. And most people did not think it was possible. They just said, why would you go into a field like that? The brain and the skull just should not be opened except in emergency situations. And by the end of his career, the mortality was about 8%. So he really made brain surgery safe. And then there were other pioneers after that who made it more and more effective, introducing, for example, the microscope into what we do. That didn't come until the 1950s, 1960s. A guy named Ghazi Yashergil, who taught us how to do microsurgery. And that made our intervention so much more effective and so much safer because we could actually see what we were doing at the level we needed to see it. Things you see with your naked eye are just not the right perspective You can see, centimeters with your naked eye, but with a microscope, you can see microns and millimeters much, much better. And that's really what you need to be able to see to do effective neurosurgery. And now we're using computers. We're doing molecular neurosurgery. We're implanting, we can talk about that as well, brain-computer interfaces into the brain. So there's just so much more in the field that's just so rapidly developing and expanding as technology advances.
What was killing those early patients, half of them? Was it infections or direct effects?
Yeah, I mean, it was infections. It was also brain swelling. When you touch the brain or you damage the brain, it starts to swell if you don't know how to control it. And there are medications we give. You also need to be able to see all the blood vessels, because if you accidentally damage a blood vessel, you'll get a big stroke. So they couldn't really see. They would operate in rooms that had open windows, right? That's how they got light in there.
Oh my God, it's
right.
crazy.
It is crazy. But obviously anesthetic, anesthesia, and antisepsis, which were already being developed at the time, were what were necessary to make neurosurgery safer. So Cushing also benefited from the technology that was being developed in his day, just like we benefit from the technology of our day, which is mostly computers and robots.
Yeah, this isn't in your book, but I was thinking about it when I was reading it. The trephining of these skulls from thousands of years ago. What were they doing? Any idea what they were thinking they were doing?
Well, their theory of health had to do with spirits, invading the brain. I think they were trying to let out evil spirits, and they would, open the skin and really scrape away at the skull to let evil out of the head if someone was possessed by some sort of a demon.
And some of those openings healed up, so they survived, and some of them didn't. So obviously they died. It's just crazy.
It is crazy.
Yeah, when I was in graduate school, physiological psych course, we studied Wilder Penfield. So talk about him a little bit. Another one of these pioneers.
He's one of my heroes, really, because he was someone who said, hey, we're opening up the brain. Why don't we learn something about how it works? And he treated a disease called epilepsy. And neurosurgeons, brain surgeons for years have used the disease of epilepsy as a window onto the mind and to learn about the connection between the brain and the mind, which essentially are the same thing. The mind is not a separate entity from the brain. And he did a lot of his surgeries awake, where he would stimulate the brain in different areas and showed that, if you stimulate a certain area, the arm will move and the leg will move. And other areas he would stimulate would control language. And he was able to map out where language abilities precisely were in all different types of patients, and even could stimulate some areas and patients would relive memories from their past, which he called experiential phenomena, which led him to believe that we have recordings of all of our prior experiences hidden in our brain somewhere that could be released with the proper stimulation. But he was really not only a pioneer of brain mapping and learning how the brain works, but most of the black neurosurgeons in the 1950s in America couldn't get any training in American institutions and actually had to travel up to the Montreal Neurological Institute and trained under Wilder Penfield. So he's also a bit of a diversity hero as well in moving our field away from just being dominated by white men.
Amazing. Yeah, here's that picture of the mapping of the body, or the sensory organs that Penfield did, of how much more of the cortex is devoted to lips and fingers than, say, legs and arms and back.
Which tells us so much about who we really are, and what the brain cares about and what evolution cared about to get us to the point where we are, which was really our ability to make things and our ability to communicate has put humanity where it is as the dominant species on our planet.
Yeah. By the way, I'm in agreement with you that I'm a monist, materialist. I think of the mind as just a word we use to describe what the brain is doing when it's doing something. It's just a process. But I have to say, there's a lot of neuroscientists or people that are in the consciousness studies area who don't agree with me. They think they are some kind of dualists, that consciousness is floating around somewhere separate from the synapses and all that. What do you make of that?
I find it a little shocking. I think that as a brain surgeon who's interested in philosophy and who's read a fair amount of philosophy of mind and philosophy of language, having hands-on experience, actually touching the brain, removing parts of the brain, seeing how that affects people's personalities, their behavior, their sense of self, reading papers about, and putting electrodes in human beings' brains and seeing how those neurons fire when they talk and when they speak, I think helps you get a perspective that just eliminates the concept of there being anything else but brain, because there's no need for there to be anything else. It's just an additive extra piece of information that just makes things much more muddled and confusing, and it doesn't make sense of why you need it.
There's something about consciousness because we're aware of it, I guess, and we're not aware of, say, what my pancreas is doing. So no one would ask, well, where does the pancreas process go when you die? It doesn't go anywhere. It just stops doing what it was doing. But for some reason, the brain, where does the mind go when the brain dies? Same answer. Doesn't go anywhere. It just stops functioning, right? But
Well, I
it
would say
feels different.
it doesn't go anywhere because it never existed, is what I would say. The hard problem of consciousness is the problem. Like, we don't understand why it's like something to be you, and why you see the color red when the color red doesn't really exist. That is not adequately explained by science. There's no question. But that doesn't mean you have to create something called mind. It just means we don't fully understand why it's something it's like to be you and to have those experiences, as opposed to being essentially a zombie that has no inner narrative. But we know that we create narratives, and you can think of reasons why having a narrative would be advantageous to an organism, to make sense of what you're doing and to feel like your identity is special and unique, because we want to preserve ourselves, because we're basically just passing on DNA from generation to generation. And I think having that unique identity of a self is evolutionarily advantageous to us to try as hard as we can to preserve ourselves.
Yeah, I've had discussions on this show with Christoph Koch and Philip Goff and Bernardo Castro, Deepak Chopra, and so on about this issue. They all disagree with me on this, but I'm with you. It doesn't go anywhere. When you take out a piece of it, like I asked Deepak, where does Aunt Millie's mind go when her brain memories die of Alzheimer's? I mean, where do those memories go? And he said, well, they float off back into the ether or wherever. It's like, well, but doesn't it suggest that if that little patch of neurons there in the temporal lobe that recognizes faces, was that the fusiform gyrus? If you take it out, well, that means that's what that was doing. And it's just not doing it anymore. It's not like facial recognition floats off into the quantum field or something like that.
That's correct. And we all know there's the famous story of the man who mistook his wife for a
Yeah, I
hat,
love
the
that.
man who had of Oliver Sacks. Of course, anyone who's writing anything about neurology or neuroscience loves Oliver Sacks, and he was a big influence on me. I read everything he wrote in college. But obviously, this was a gentleman who had a stroke somewhere and no longer could recognize his wife. And it just shows you that those things that we think are so important to who we are and our identities. I like a certain type of music. I'm married to a certain woman who I recognize. I, like the taste of chocolate. Maybe I don't like the taste of pickles. If I can change my brain in such a way that all of those tastes will be altered, do I become someone else? Or am I still myself? And if I'm still myself, well, if all those things were how I identified myself and I can change them with a flip of a switch, what does that mean about the self and my identity? So I agree with you.
Yeah. Now, Christoph Koch's answer to a challenge on that, it's not possible to know what it's like to be somebody else or something else, a bat or a dolphin or whatever. It's the hard problem is conceived, it's conceptually misphrased, I think. He thinks that we just haven't figured it out yet, another 25 years, 50 years. He just lost that bet with David Chalmers after 25 years. They haven't figured it out. I don't think they're ever going to figure it out because of the way it's phrased. I mean, just think of it as some other way. The easy problem is actually pretty hard. It's what people like you do, but the hard problem, I just don't see how it's conceived. I could ever possibly know what it's like to be you, for example. I can't possibly know that. As if it's a little homunculus in my head goes over into your head and goes, oh, the red in his head, his Cartesian theater looks just like mine. I mean, it's not possible. This is crazy.
Yeah, I think a lot of it is built into our language. We see the world and appreciate the world through the categories that our language creates for us. And our language creates a lot of illusory categories of things that don't really exist as we imagine them to exist. And mind is one of those things. Even the color red, by describing it as red, We could describe it as a wavelength of light, which does exist. We know that exists, but we describe it as red, so we think it's different than the wavelength of light because it's our experience of that color red. And it's just the neurons in your brain processing that color of red, firing in a particular pattern. That's all that experience is.
Yeah. So the evolutionary psychologists talk about the mind as they used to call it a Swiss Army knife. Now they've upgraded to a cell phone with all of the different apps. Okay. But the idea that there's a self, there's no self, there's no module there it is. It's in the pineal gland or whatever. Right. But might you think of it as like a higher order emergence of a bunch of different apps running, and that we kind of subjectively feel like I'm me and that's as good as it gets?
I think we try to create a lot of metaphors for what it's like. And when you're creating metaphors for something, it means you really don't understand it and you're just telling a story to make sense of it. One of the things I try to do philosophically at the end of the book is say, how has brain surgery contributed to our knowledge of the self? I'm not a professional philosopher. It's not what I do for my living. But I've read a lot of brain surgery experiments, and I go into some of those experiments, and they have significant ramifications. So we can record from neurons in the brain that are important in moving a limb, and ask someone, when do you make the decision that you want to move your limb? And they'll move it at a particular moment, and they say, yeah, I decided to move it a little bit beforehand, and we'll record neurons in the brain that are firing about a second before they made the decision to move it. So then the question is, who made the decision? Did your brain make the decision for you? And then you became aware that you were about to make a movement, and you created a story saying that you were going to move your hand. And that's why you think you had agency over what you did. And the same is true of language. We can record neurons that are firing, that are important for creating words. And those neurons will fire literally a full second before someone has even thought of what they want to say. There are other famous experiments identifying, as you mentioned, neurons that respond to individual people's identities, not just their faces. And the famous one was the Jennifer Aniston neuron, where an experiment was done by a neurosurgeon named Itzhak Fried, showing that there was a neuron that would fire every time the person thought of Jennifer Aniston, saw a picture of Jennifer Aniston, someone said the word Jennifer Aniston to them, the neuron would fire. But the neuron, when they thought of Jennifer Aniston, would start to fire about a second before they knew they were thinking about her. So you start to read more and more experiments like that, and you start to wonder who's in charge, and who's really making things happen, and are we just not making up stories after the fact? And when you take that information and you look back at the split brain experiments that I write about that were done by Michael Gazzaniga, and those, by the way, those experiments only happened because neurosurgeons happened to be splitting the brain to treat epilepsy. So it gave an opportunity for the neuropsychologists to study one brain separated from the other. And Michael Gazzaniga was able to insert information into the right hemisphere of patients' emotions and behaviors that the patient would feel or that they would carry out. And then he would ask them, why are you doing that? And he knew that it was because they were inserting the information into the right hemisphere that has no language. And the left hemisphere that wasn't aware of the information that went into the right hemisphere would then make up a story as to why they were doing it. Oh, I feel scared because you're wearing a scary tie that's frightening me, even though a scary image was put into their brain. Or I'm moving my hand to point at this object and make up a story as to why it was based on what the left hemisphere saw, but not based on the information that went into the right hemisphere. So those kinds of spooky experiments make you realize that there's an enormous amount of processing in the brain that goes on below the level of our awareness and our consciousness that it influences our behaviors, and that we often justify afterwards by making up a story as to why we behaved the way we did, so it makes sense to us.
Yeah, Gazzaniga is a longtime friend here in Santa Barbara, where my office is. And I love his story about the woman who had some sort of amnesia disorder in the hospital, and she thinks she's home. So the surgeon takes her down to the hall to the elevators. He goes, well, how do you explain these elevators? Bank of elevators. Doc, do you have any idea what it costs us to put these things in?
That's great. That's great.
So funny. I actually think all autobiography is we just make stuff up. How did you become a surgeon? How did I become what I do? Whatever. You just kind of look back and go, okay, here's my pathway, which was mostly just random, right? You're just bouncing. It's a random walk. It's the drunkard's walk in a way. And for most people, it is anyway. And after the fact, you just sort of piece it together like that. I think it's all like that. Anyway, so yeah, the self. So I think of it. Oh, so I think back to the free will thing. You talk about Benjamin Lebet's experiments in there, and the upgraded experiments since then, where they could predict like 3 or 4 seconds before you know what you're going to decide. The neuroscientist knows what you're going to decide before you do. But Lebet was a compatibilist at the end. He wrote that memoir before he died, and he came out as a compatibilist. He still thinks of it as a kind of volition or choice where you're aware of the options, you know what's happened in the past, you know what you've done before, and then you look at the options and you kind of select one. Now, even though the whole system is deterministic, we live in a determined universe, but it's not predetermined unless you have a cosmology of like a block cosmos where the entire universe has already happened and we're just in this little slice. The future is not predetermined, so you are part of the causal net. Now I'm reflecting my own thoughts on this. As time flows forward, you can't step into the same river twice because the water's not the same and you're not the same. So you can, based on what happened in the past, so I'm going to go left this time, or I'm going to have the chicken instead of the steak, or whatever it is. Is that not, I think of it as a kind of volition or a sort of a choice or self-determined?
So I agree with you. I'll tell you what I've concluded. I think we live not in a determined universe, but a probabilistic universe. And there are some futures that are highly, highly probable, but they're not absolute. It's not 100%. It could be 99.9%, or in some circumstances, 75%. And I think that's compatible with sort of a quantum view of the world as well, where things are probabilistic in terms of their locations and their momentum, but not fully determined. And I think that the way the brain works is we will experience something, and there are multiple modules in the brain that are processing that information and coming up with ideas as to how you should behave. And you are going through each of those different possibilities, and you choose the one that is the most probable, that seems to be the best option for you at the moment. But a different one of those modules selections may have risen to this top at that moment in time based on everything that's going on around you and based on your biology and your DNA. And you can do things that are improbable that other people would say, why did you do that? Why did you behave that way? The module telling you to, drink milk instead of coffee is the one that should have won your decision making. But it doesn't mean that you have control over it. It just means that all those different probabilities were weighted based on the mechanisms and weighting in your brain. And the one that rose to the top to become the one that you carried out may have been an unlikely one for other people, but for you, it was the higher probable one at that moment in time.
Oh, that's a nice way to put it. That's really good. I always like Dan Dennett's idea of degrees of freedom. And so he acknowledges that people that have brain tumors or whatever went wrong in their biology that caused them to become school shooters or up in the tower like Whitman or, some of the other examples. But you and I are not like that. We don't have brain tumors. And it's not brain tumors all the way down. Most brains are not broken. So we can acknowledge that, the criminal who is driven by this horrible background or whatever his biochemistry is or a tumor pressing against his hypothalamus or whatever. But you and I don't have that problem.
Yeah, I actually looked up records from Whitman because I was interested in that case.
Nice. Yeah.
And what I found out, and I pulled up a pathology image of where the tumor was in his brain. And the tumor was not in his amygdala and hippocampus. It was near it, but it wasn't directly in it. And I think that is a fanciful story. The fact that we think that Charles Whitman was motivated by a brain tumor to go off his rocker and start shooting people down at the University of Texas.
Oh, that's so
I see patients all the time who have tumors in their medial temporal lobes, who have seizure from the medial temporal lobe. And, doing something like that that's so unhinged does not happen very commonly, very, very uncommonly. There are so many other reasons that Whitman may have done what he did. And I read a couple of books about him, and I was thinking of writing a chapter on that. Reinterpretation of that case because he had other motivations. I mean, look, we all know people who, for psychological reasons, who don't have, and most of the people who shoot people and go crazy like that and are sociopaths don't have brain tumors, right? And every once in a while, you're going to find someone who is a sociopath who happens to have a brain tumor, but it doesn't mean the brain tumor is what explained his behavior. It could be true, and unrelated, and not a causal relationship. So I have a different interpretation of that case.
That's great. I love that story. Write that up. We'll publish it in Skeptic. I love that.
Sounds good.
It's the kind of thing we do. Well, I mean, again, this is that after the fact storyteller. I think we also do that for things like that. We want an explanation for the school shooter. Probably there is none, and there never will be, because of the role of contingency, chance, randomness that happens in people's lives. You know, you go left instead of right, you do this, that, and, and 200 steps later, you're a crazy school shooter. And we want that simple, there it is. It's right there and next to the hypothalamus. You can see it in the brain scan. I don't know if you ever read, I didn't see Adrian Rain's books cited in your, but I don't know if you read his book, The Anatomy of Violence. But he contrasts two people. He has Mr. Oft, OFT, who had a orbital frontal cortex, a tumor in his orbital frontal cortex. And he was the middle-aged guy that became a pedophile. And his wife, he was like being inappropriate with the stepdaughter. His wife turned him in. And so he's in big trouble, and he's about to go to prison. He's in court, and all of a sudden he pees his pants right there in court. And the psychiatrist is like, hey, maybe we ought to scan this guy's brain. That's not normal. So they do, and he's got a brain tumor. They take the tumor out, and he no longer has any of these pedophilic feelings. And then 6 months later, the wife catches him with kiddie porn on the computer. Back in the scan, the tumor's grown back, right? So then Adrian Rain contrasts that with Donta Page, who was this young African-American man who was on trial for rape and murder of a woman in Colorado. He's being faced with death row. So Adrian Rains was on the defense team to argue for life in prison instead of capital punishment. Anyway, he spends like 3 pages on this guy's background. There's no tumor, but this poor kid, was raised in the worst neighborhood, single mom who's drug addicted, series of men that beat him. He's part of gangs. He's in the hospital. He has hit in the head, like half a dozen times, and concussions and this and that. And, by the time he gets to be 20, when he commits the crime, he's had like the worst possible background you could ever have. But it's not obvious on a brain scan. It's not like you go, oh, there it is right there, right? So this was his point, that most of the time we have no idea what, all the little things that happen in a lifetime go to determining those kind of behaviors.
Yeah, I think I agree with that. It's the concept that the machinery of the brain and the modules in our brain can be broken for a variety of different reasons. It can be external force. It can be a tumor. That can happen. It definitely affects behavior and personality. We can put electrodes in the brain and change someone's behavior and someone's personality. Or it could be the way they were developed and the way they were treated and how all the modules in their brain formed over their lifetimes through Hebbian learning and experience. All of those things program our brains and also the DNA that you're built with. It's really neurons all the way down. There's nothing else but that. I haven't read that book, but I do look forward to reading it. And I think people always say, well, if you don't really believe in free will and autonomy in the self, like what about morality? And, how do you punish people for doing anything wrong? And you do anything you want. But the answer, of course, is that there are machines that are broken, and sometimes those machines have to be fixed. And hopefully, you can rehabilitate someone who has a broken machine and it's not compatible with society, and they need to go into a prison, and hopefully, we can fix their broken machine as opposed to just throwing it out.
Yeah. All right, let's go through some of the really great stuff in the book. Brain injuries, head-on collisions, sports injuries, CTE, boxing, all that stuff. What's going on there? What do we know?
So you want to talk about TBI?
Yeah.
Okay, so CTE, chronic traumatic encephalopathy, is a disease that was first described in boxers in the 1930s when they would get punch drunk. And we know that boxers who continuously get hit in the head will have long-term damage. Some of it is a movement disorder in boxers, but it can also be cognitive, decision-making, emotional, irrational behavior. And then, of course, the NFL had a situation where their players started to have more and more long-term problems from the frequent concussions and subconcussive events that they were having. The NFL very much tried to hide that, and they hired a guy named Elliot Pellman, who was a rheumatologist, to be the head of their brain injury research, which is ridiculous, by the way, to get a rheumatologist to do that. And he published a series of articles in the neurosurgical literature trying to show that concussions were not a problem in the NFL, and athletes could go right back into games. It wasn't an issue. And the neurosurgery reviewers of those articles tore them to shreds eventually and said, look, this makes no sense. At the same time, a couple players who died had their brains examined by a pathologist named Benedetto Malu. And he also published in the neurosurgical literature, hey, there's these long-term chronic changes in their brains. They have these proteins that are building up in the brain, tau proteins, and these are manifestations of chronic traumatic encephalopathy. And he just thought the NFL would want to know this. And the NFL was just brutal in tearing apart all of those articles and saying they were nonsense and they were poorly done. And as time went on, we realized that in fact it's not nonsense. And it is a fact that the more head injuries you have, the more likely you are to manifest this disease, a traumatic encephalopathy. Boxers get it. People in the military also get it when they're next to rocket launchers that are constantly experiencing blast injuries to their heads. And if you start playing football at a very young age, like if you're 6 years old and you're already tackling, by the time you're 26 or 30, you've probably had enough hits that you can develop chronic traumatic encephalopathy at a young age. You don't have to be a professional football player. So, it's a real thing. It's dangerous. But probably a couple years of high school football is not enough to do it. But the other important thing is you have to be a susceptible individual. And that's what creates the question of whether CTE is real or not, or whether concussions are really causing these events, because we all know football players who go through long careers and then they end up, as NFL announcers, and they are sharp as a tack. They're super smart. But there are others who are not, right? So there's also a genetic component to it. It's not so simple, as most diseases are. It's not just environmental. It's a combination of a genetic thing, predisposition, and the environmental influence that play together to create the disease. And now, it's a known thing. But the bottom line for the NFL players, in my opinion, is these guys are well paid. They know what risks they're taking. And they're playing a beautiful game that they want to play. And it's going to pay them handsomely to do it. It's going to change their lives and the lives of their families. So if they want to take a known risk to make that kind of money, then they should have the free reign to do that. We shouldn't restrict them, but we should make the game as safe as we possibly can without changing the very nature of the game itself.
Yeah, I like that. I agree with that. You got to have some libertarian structure there. Paternalistic, what do they call it? Libertarian paternalism, right? We have some structure, but let people make those choices. Although there was that survey done of Olympic athletes, I don't know, maybe 20 years ago. Would you take a performance-enhancing drug that would give you a gold medal, but it would shorten your life by 20 years? They all said, yeah, a gold medal. Of course, these are like 20-year-old guys, right? So that's a bit of a problem there. Yeah, the CT, there was that great movie. Will Smith played the doctor that exposed it initially. And it was they started off with Mike Webster, the center for the Pittsburgh Steelers. And they had, I don't know if this was from the movie or something I read, but it was something like between high school and the end of his career. And he's a center. He's right there in the middle of that. Every play, bam, bam, bam.
Yeah.
And then all the practice games and the preseason games. And, that he must have been hit in the head like 1,000 times, or maybe it was 10,000 times or something like that. How could that not have an effect?
And the NFL sort of said, well, how could it be CTE? He's never had a concussion. Because he never reported one, or they never identified one. But all the players are hiding their concussions. They don't want to come off the field. They want to play,
right.
And the doctors were paid by the NFL. So they're not reporting the concussions either, because they get paid by the teams, the doctors back then, to keep their players playing. But I think it's pretty obvious that there is a direct cause, although the international leagues still don't recognize it. The international football leagues and rugby leagues, NASCAR, not NASCAR, but Formula One. I think those international organizations don't yet accept CTE. They think there's just too much ambiguity, too many questions out there. But, the truth will come out. Science will win the day in the long run, as it always does.
Like with tobacco.
Exactly.
Yeah. Oh, by the way, last night I was watching that Netflix roast of Tom Brady. Have you seen this?
I did.
Oh, my God. That bit about that Nikki Glazer has, where Tom Brady is on her. Tom Brady's on my fantasy league. In fact, last night he was on my fantasy team, and now I have my clit has CTE, and I was going to show it to you, but the NFL made me cover it up. It was such a great bit.
Yeah. There was. I watched that and I said, there's a third of this that is really, really funny, and a third of it that's not that funny, and a third of it that was just completely offensive to me. But there was about a third that was hysterical.
Yeah. It's amazing how raunchy comedians can get. Anyway, so, okay, let's see. So let's talk about some of these famous cases. Muhammad Ali, was that Parkinson's or what was that?
So, I think that what he developed was a Parkinsonian syndrome, right? It wasn't Parkinson's disease, it was a syndrome, and it was related to his boxing. I think most people think. I actually
Yeah,
spoke to his neurologist. I
yeah, that's a great
called him
story.
up because I wanted to do a little research and get his opinion on that. And he had a type of CT. The boxers have it a little bit differently than the football players, and it tends to be more of a movement disorder and to look more like Parkinson's disease. He never wanted his brain examined. I think he didn't want to seem like he was a traitor to his beloved sport of boxing and didn't want to blame it on boxing. And I certainly respect him for that. He did investigate getting a transplant of dopamine producing cells by a neurosurgeon in Mexico, which many people don't know.
Hmm.
He would not have been a great candidate for a deep brain stimulator, which helps mostly with movement disorder, because what he had more than tremor was really slowing of his cognitive abilities, and trouble initiating movements more so than a tremor. Whereas Michael J. Fox really had a bad tremor, and that's why he went for a brain surgery, and Muhammad Ali did not.
Yeah, interesting. Okay, let's see. Oh, Ava Perón. That was another interesting one. I had no idea. Never heard that. Tell us that story.
Well, I talk a lot about the frontal lobotomy, right? I think that was a very important time in neurosurgery as well. And as the son of a psychoanalyst, I very much love the fact that there was this skeleton in our closet that I never learned about. When I trained in neurosurgery, never once was a frontal lobotomy even mentioned to me in my
Hmm.
training. And it was a period of time in the 50s and 60s where 60,000 frontal lobotomies were done in America to treat mental illness. And the story that I tell, I sort of wanted to look at how complicit neurosurgeons were in the frontal lobotomy. Was it something that everybody was doing? We thought it was a great treatment. Was it something that we were skeptical about? And it turns out that most of the physicians who invented, created, pushed the frontal lobotomy were neurologists and psychiatrists. There really were not any neurosurgeons who leading the charge. But there were neurosurgeons who did frontal lobotomies for sure because they were demanded by the public and they were studied. There were some neurosurgeons who did very rigorous studies where they would take 100 patients, they would have psychiatrists evaluate them, they would do a frontal lobotomy on half of them, not do a frontal lobotomy on the other half, have them re-examined by psychiatrists who were blinded to whether they had a frontal lobotomy and say, hey, did anyone get better? And it turns out that there are a bunch of people who actually got a lot better by having the frontal lobotomy. So it wasn't a completely horrible operation, but it did have too many risks, too many complications. It blunted and dulled many people's personalities, like Rosemary Kennedy, a famous person who had a frontal lobotomy. So the story of Eva Peron, I wasn't that familiar with either, and it's something that was in our neurosurgical literature, just like the JFK assassination I talk about. It's information that we know from what's published by neurosurgeons that the general public does not know about. So there was a guy named Poppin who was a very famous neurosurgeon at the Leahy Clinic in Boston, very well respected. And he did frontal lobotomies and he enjoyed doing them and he was proud of the fact that he could do them very, very safely. And he did a study showing that it worked in a certain number of patients. And he was friends with Juan Perón, and Juan Perón called him down to Argentina because Eva Perón, near the end of her life, was dying of metastatic cancer and she was in excruciating pain. And the frontal lobotomy was not just done for psychiatric illness, but it also helped people deal with chronic pain because they didn't really care about the pain anymore, right? So Juan Perón called him down to do the frontal lobotomy, but before he operated on Eva Perón, because he wanted to make sure that he had the right equipment and that it would go safely, Juan Perón asked him to operate on a few prisoners in the local prison. And this guy, the neurosurgeon Poppin, didn't examine these patients. He didn't know if they had mental illness or not. He just did frontal lobotomies on these people because a dictator, an authoritarian dictator said, hey, these people need lobotomies, which is a horrible thing to think about, that a neurosurgeon would do it for that kind of an indication. But then did a frontal lobotomy on Eva Perón, and it was discovered later by another neurosurgeon, an Argentinian, who did the investigation and eventually found the nurse who was assisting Poppin and who confirmed that, in fact, he did go down there and do Eva Perón's lobotomy.
Amazing. In her early 30s, right?
Yeah, she was very young.
And then you suggest that maybe there was some behavior control motivation as well. Maybe she was getting out of control.
Yeah, she had an army that she was raising to sort of overthrow the government because she was very much a populist, felt that people weren't being treated well, and was becoming very military. There was a whole military wing that she was running, and it's possible that Juan Perón was trying to subvert her revolution by lobotomizing her, which is crazy.
Amazing. That wasn't in the Madonna movie.
Yeah, I missed that part.
Yeah. Okay. So the two kinds of brain tumors, meningioma and glioblastoma multiforme. You want the latter one, not the former one. The glioblastoma will kill you.
Yeah, that's
What's
the
the
bad
difference?
one. Well, there are about 170 different types of brain tumors. There are many, many different types, and a lot of them are benign, and some of them are malignant. People have only heard of a few of them, and I only talk about a handful of the most common ones. But benign tumors are tumors that form in the brain. It's one cell starts to divide. That's what a tumor is. It's one cell that shouldn't be dividing that starts to divide, and it can be any cell in your body, which is why you can get tumors in your lungs and in your pancreas and in your kidney. And in the brain, one of the more common tumors comes from the covering of the brain called the dura, and it's called a meningioma. And it just grows in one area, but it doesn't spread anywhere else. And if a neurosurgeon goes in and removes the tumor, we can cure patients. And that's an amazing thing because these tumors can cause severe symptoms. They can make you weak. They can cause seizures. They can make people go blind. And we can remove these tumors and basically restore vision, make people regain their strength that they're losing. And so it's a remarkable intervention that neurosurgeons have the privilege of doing, saving someone's life, taking out their tumor, curing them, restoring lost function. Unfortunately, there are other tumors that are malignant that invade into the brain. And what makes them malignant isn't that they spread all around the body, which is what we think about with some other malignant tumors, but they spread through the brain. And they basically intercalate. They have cells that will grow into the brain all the way to the other side of the brain. In fact, if you try to take the tumor out and become more and more aggressive, there was a neurosurgeon named Walter Dandy who removed the entire half of a brain in someone who had a glioblastoma, and the tumor just recurred on the other side of the brain. So they really spread everywhere. So they're not curable, unfortunately, certainly not with surgery alone. So we treat them also with radiation and chemotherapy afterwards. And there are some long-term survivors, which is wonderful. And there's enormous amount of research being done to try to cure these tumors. But it's a dramatically different experience for a patient and for the physician dealing with a malignant tumor versus a benign tumor. And it's important for people to know the difference.
Yeah. All right, I'll tell you a personal story. So in early 91, my mom started acting really weird. And my parents had just lost a huge amount of money on a land investment. They got scammed, and they grew up in the Depression. So they were always worried about losing all their money and stuff. And so I thought, well, maybe that's it. But it wasn't just that she was depressed. She was doing weird things like putting the milk in the microwave, that kind of thing. So I took her to a psychiatrist in Pasadena and said, well, I think it's probably severe depression. Let's do 6 months of antidepressants and see how it goes. And I was just sitting there going, are you sure? Because she's acting really weird, not just depressed. She goes, well, yeah, let's just try it. And I said, well, could we get a second opinion? She goes, yeah, sure. Here's a neurologist in Pasadena. So I said, can I call him now? And she's like, now? I go, yeah, can I just use your phone here in the office? So I get on the phone. I go, this is Dr. Shermer, and I'm over at Dr. So-and-so's office, and we need to get a patient in right away. And this woman, psychiatrist is like, what is this guy? Anyway.
Good for you. Good for you.
Yeah, I'm a PhD, not an MD. Anyway, so I get her in there, and appointment that afternoon. We go to lunch, and we go down there, and there on the scan is a huge. I mean, it is like I don't know, a small orange or something. It's huge. It's obvious, and it's like, oh my God, okay, that's the problem. So.
Yeah.
And it's a meningioma tumor. So they took it out right away, and her brain, I guess fills right back up. It's amazing, apparently, how fast that happens. And then so everything was normal again for, 6 months or so. And then, they're doing the periodic scans, and it grew back in 2 different places.
Wow.
Okay, so they go in and take those out. And then 6 months later, there's like 4 different places. Like, okay. And then I started doing some reading and stuff, and I came across this guy here. I wrote about it, Jonah Faulkner at Harvard. Folkman. With his controversial angiogenesis theory of cancer, which he developed in the 1960s while conducting research for the U.S. Navy. Folkman noticed that tumors planted in isolated organs in glass chambers all stopped growing at a certain size. their size range would have exhibited the classic bell curve, so he deduced that it was a lack of blood vessels in tumors. Anyway, he noticed that the tumor, you'll already know all this stuff. I'm just kind of filling this
It's
in.
okay. It's great stuff.
That the tumors all were filled with blood vessels. And how did the blood vessels know to grow there? These tumors must be secreting something that draws the blood vessels to them. Anyway, he presented this in the New England Journal of Medicine. And I guess he was heavily criticized because, what do you know? You're just a surgeon. You're just a guy that cuts stuff. Leave this to the serious theorists, right? So I thought that was an interesting sociology of science, right? You can't listen to this guy. Anyway, so he developed his angiogenesis and then the anti-angiogenesis. So then I started checking with my mom's doctors, USC, Norris Cancer Center there. Are there anti-angiogenesis drugs that might? Yeah, there are. So we tried some of those, and then it kept growing back. She had 5 craniometries, and then after the 5th one, they go, "That's it. We're not doing any more of these. It's just too much for your mom's skull and brain and all that stuff." And I didn't know about that stuff about you get seizures. You have to take anti-seizure medications. I know a lot of people that think what Elon's doing with the Neuralink is great. Yeah, I'm just going to do this. I'm going to open my head up and I'm going to put chips in there. You're like, hang on. Don't think about opening your head up like, oh, this is just no big deal, right? I mean, it's a pretty big deal, as you know. Anyway, so then she had 5, what do you call it, gamma knife radiations with the helmet on the head and all that stuff. But they just kept growing back. And so then so here's my message for what I do here is, to the alternative literature. The problem is there's not like one alternative to what you guys do, right? There's like 100 of these alternatives, none of which have any proof at all. And I'm not going to drag my mom to the Philippines or to Mexico or something to try some quack cure just in case. And so, in terms of what's the harm, well, that's the harm. Just the energy, the time, and there's not one choice alternative. There's a bunch of them, and none of them work. Anyway, so we finally got a permission to use this. What was it? It's the mifepristone RU486, because there was some small study showing that may be an anti-angiogenesis that suppressed tumor growth.
So just to correct you, meningiomas have receptors for progesterone and estrogen. We know that.
Oh, okay.
And RU486 blocks that. That's how it works for pregnancy. And that's not an anti-angiogenesis drug. It's a drug that blocks female hormones, and those receptors are on meningiomas.
Why are women more likely to get this than men? Is that true?
They are.
Yeah.
Yeah, they are for that reason. Men still get them.
Yeah. Anyway, it ultimately killed her. She just fell and hit her head at some point because of all the stuff that was going on, and was in a coma for a while.
So you raised a couple of points, if you don't. Well, were you going somewhere in particular?
No,
I don't want to interrupt you.
That's it. Yep, that's it.
First of all, I'm sorry about your mom.
Well, it was 10 years. I mean, I had plenty of time to say goodbye and tell her how much I love her and all that stuff. So
that's great. Good for you. So, I said meningiomas are benign, but it turns out they're a subset of meningiomas that can act very aggressively. And your mom obviously had one of those. And we now know genetically how to identify those meningiomas that are very aggressive. And we call them grade 3. They're anaplastic and malignant meningiomas. They're very hard to treat. And we try surgery. And really the only way to treat meningiomas that we all agree on is surgery and radiation. And she had those, and I talk about gamma knife and when we use radiosurgery to treat different neurosurgical problems. But eventually they sort of they fight against everything we can throw at them, and then they keep growing. So I'm sorry that you had to go through that. Judah Folkman, is funny that you mention him, because I went to Harvard Medical School, and he is one of the heroes. If you go to Harvard Medical School during the era when I went there, like he would literally teach, and he was there. He would give a lecture in almost every course that we had, because he knew everything about everything, and he kept coming back and giving more lectures. The story that was told that I tell in the book, I think was about him, even though he wasn't a neurosurgeon, that he was so dedicated to surgery that he once went into the hospital and stayed in the hospital as a resident for 100 days straight. Never came home. And his wife actually left him and felt so guilty, she came back. And because he was away for so long, he left, and 100 days later he came back. He didn't realize that his wife had left him and come back several days later. He was completely oblivious because he had been in the hospital for so long. It's just a story about the dedication of residents. But I do talk about, you mentioned the idea that he came up with the idea for angiogenesis, and no one believed him. almost every revolution in brain surgery over the years has been put down by the more senior surgeons. And that was true of the microscope when Yashragil invented it. I tell the story of his senior surgeon who never let him do any surgery, didn't believe the microscope was going to be as revolutionary as it was. The treatment for Parkinson's disease was stumbled upon accidentally by a neurosurgeon named Irving Cooper, who was doing a surgery on a patient with tremors, and he caused a stroke by accident. And at the time when he was doing the surgery, the prevailing conventional wisdom was that you could not stop a tremor without paralyzing the patient. And he caused a stroke by accident, and his patient woke up and his tremor was gone and he could still move his arm. And so it was just a serendipitous discovery that he then spent the rest of his career trying to figure out how that happened and developed the surgery for Parkinson's disease that we now do today, where we make a lesion in the thalamus or the globus pallidus part of the brain. But nobody believed him for almost his entire lifetime. Nobody believed that what he was doing was real. And the same was true when I started operating up the nose and taking out brain tumors going through the nostrils. Most of the senior surgeons who heard that said that is malpractice because all your patients are going to get brain abscesses, they're going to get infected. And they didn't. And we proved to them, a group of us, that it was a better way to take up these tumors. And now it's become the standard of care. And I saw that transition in my short, 25-year career from a surgery that I was never taught to do, that never learned how to do, never saw done. And now it's become the standard of care. And I have, surgeons flying in from around the country learning how to do a bunch of different minimally invasive surgeries that have been developed only in the last 10 or 20 years.
Amazing. So why is that? There's what's called the Planck problem. Ernst, yeah, that's right, Planck. Yeah, that for a new theory to be developed, the old guys have to die. Science progresses one funeral at a time. Is that right? Because most new ideas turn out not to be right, so it's reasonable and rational to be pretty cautious and skeptical, or is it, just your own confirmation bias and my side bias and all that stuff that kicks in, and you're just less open to new ideas, and it's ego, or I don't know, what do you think?
Well, I think it's all of those things, right? I mean, I think it depends on the situation, but all of those things are at play. I will say that in neurosurgery, in order to have the audacity to tell a patient that I'm going to operate on your brain, I'm going to go in to the touch your most, valuable possession, take it in my own hands. You have to believe that what you're doing is the best way to do it, and that you're the best person to do it at that moment in time. And if someone else comes along and says, and they're younger than you, and they don't have as much experience as you, and they say, hey, I got a better way to do it, you're not doing it the best way, I'm going to do it a different way. I think it's very difficult for a neurosurgeon to accept that they're not doing it the best way. They're afraid of losing their patients. They're afraid of being exposed of the fact that what they're doing is not a perfect science, because what we're doing is not a perfect science, and neurosurgery is constantly evolving and getting better and better. But yet patients want to come to us and they want to believe that what we're doing is the state of art, best possible thing to do. And it may be at that moment, but it also may be at that moment in my hands, this is the best way to do it. But it is possible that in someone else's hands, there may be a better way to do it. But it's very hard to know, who that person is going to be. And so we have to convince ourselves and our patients that we're really doing it the best way, which is why those revolutions are very hard for us to accept as brain surgeons. It's just kind of inherent in what we do.
Yeah. Interesting. Oh, another side story in the middle of all that. My mom developed a lung tumor in her lungs, 2 of them, and in one of the lobes. And I remember thinking, well, it must have migrated out of her head. And the oncologist at the Norris Cancer Center, USC, they said, well, no, that doesn't happen. Anyway, that night, this is the total randomness of life sometimes, I had an invitation to a dinner party at Carol Tavris's house, this great social psychologist. And one of her best friends is Avram Blooming, who is an oncologist here in LA. And he's since become a good friend. Anyway, so I'm telling this story, and Avram goes, I think there's been a paper recently published showing that tumors can come out of the brain and go elsewhere in the body or whatever. I'll send those to you tomorrow. So he sends them to me, and I take them to my mom's doctor, and I go, oh, wow, hadn't seen that one. It's like, whoa, what if I hadn't gone to that dinner party? It's just
that's
crazy.
It's very rare, by the way. Did they find out that they were meningiomas in her lung or not?
I forget. Now I can't remember.
Right, because the most common thing was that she had a separate, may have developed a separate tumor. It's uncommon for meningiomas to spread to the lung. It is possible, but very rare.
Yeah, I would imagine so. Anyway, Okay, let's talk about memory loss, dementia, senility, Alzheimer's, all the other thing that worries us baby boomers, because it's
Well,
coming.
yeah, there is no neurosurgical treatment for Alzheimer's, and I bring
Yeah.
in Alzheimer's disease to as an introduction to how ephemeral the self really is, because
Mm.
as we get older and older and we lose neurons, who we are and the way we think and the way we perceive the world really does change over time. And Alzheimer's is just a good example of that. We say the expressions, they're a shadow of their former selves, or they're not sort of behaving like themselves. But, at what point do you become a different person? How many neurons do you have to lose or alter before you become someone else than you are? And obviously, we think we can never be someone else than we are because we have our identity and our perspective. But obviously, if our behavior totally changes overnight, we may be someone else because I'm someone different tomorrow than I will
Yeah.
be today, just because
Yeah.
like you said, the river is constantly moving. There is a new treatment for Alzheimer's that was recently described as a possibility using a new technique that I talk about in the book called focused ultrasound. And maybe we take a moment to talk about that, because the ultimate holy grail of neurosurgery and brain surgery is to be able to go into the brain and change things without actually opening up the skull. So basically putting ourselves out of business and not actually having to do any surgery. And focused ultrasound is a new technique that uses high frequency sound waves that can penetrate through the skull. And they're very, very high frequency, so way higher than dog whistles and things like that. And we have a device called a focused ultrasound that's basically 1,000 emitters of ultrasound that are created like a sphere around the head, and they all send the ultrasound waves into the brain focused at a point. And that is now a standard accepted way of treating tremors. So someone can come in with a bad tremor. We can put them in this machine. We don't have to open their skulls. We make a small lesion in the brain, and their tremor will stop. But there's another effect that we found with focused ultrasound, which is if you inject intravenously small bubbles into a vein, when those bubbles get into the artery going into the brain, if you focus the ultrasound there, the bubbles rupture and they open up the blood-brain barrier. So what's the blood-brain barrier? It's a barrier that the brain creates to prevent chemicals that may harm it from getting from the blood into the brain. So if a primitive man would drink some sort of a toxic chemical, or eat a frog that maybe would make them psychopathic, the brain would try to prevent those chemicals from getting in and would create a barrier. And so a lot of the drugs that we give our patients that they take as a pill or intravenously just can't get into the brain because of this barrier. So we now have the ability with focused ultrasound to break down the blood-brain barrier in specific places, which will allow us to now treat certain neurological illnesses with drugs that we couldn't treat before. And the hope is with Alzheimer's, that has all these plaques in the brain, beta amyloid plaques, that if we can open up the blood-brain barrier in certain areas, we will allow the bloodstream to clear the plaques out of the brain. And so there are some people, a neurosurgeon named Ali Rezai spoke about it on 60 Minutes a little while ago, using focused ultrasound to try to treat Alzheimer's disease. And those studies are ongoing. Some of the early preliminary results look good. So we just have to wait and see. But it's remarkable how technology is progressing. And with each new technique that comes in, what happens is you see it gets applied to all different types of diseases. So we can use that same focused ultrasound to now give chemotherapy to treat glioblastoma, chemotherapies that couldn't get in the blood-brain barrier. And the same is true of stereotactic radiosurgery and deep brain stimulation. All of those techniques were developed initially to treat mental illness, to try to improve the frontal lobotomy because it was such a barbaric operation. Once it was developed, they then realized, I can use this to treat epilepsy. I can use this to treat movement disorder. I can use this to treat tumors. So we basically take whatever techniques we can, and then we do all these studies to see what are the diseases we can treat with that technique to move the field forward.
Yeah. So the idea of the Alzheimer's being associated with the plaques and tangles, but aren't there some people that had the symptoms of Alzheimer's and upon autopsy, they did not have the plaques and tangles? And others with plaques and tangles did not show symptoms of Alzheimer's. So there must be multiple factors going on.
Yeah, there are multiple theories. You're absolutely right about that. It's not just the plaques and the tangles. Some people think the plaques and tangles are a cause, and some people think the plaques and the tangles are an effect. It's not so straightforward, which just means the reason we don't have a good treatment for Alzheimer's disease is we don't fully understand what causes Alzheimer's disease. Is it a blood flow problem? Is it the protein problem? And so we're just not there yet with the science, unfortunately. And that's why it's still such a devastating disease, because we don't have a treatment.
Do you know my friend Rudy Tanzi, who works on Alzheimer's at Harvard?
I don't.
Okay, he does some of the genetic stuff, developed some of the genetic tests. I did the 23andMe thing to see if I had the two, whatever the element, the genetic predispositions, or I didn't. But even that, they even have a disclaimer in there and saying if you have these two, it only increases your chances of getting Alzheimer's by like 2%. I'm like, oh, okay. So they don't really know.
Yeah, there's a lot of stuff that we can test for that we can't do anything about, or that may not be as significant as we think.
Okay, strokes and aneurysms. Are there any proxies or predictors for that other than just bad luck?
So these are diseases of blood vessels, and very similar to heart attacks. All the things that would create a heart attack in someone will also lead to aneurysms and strokes. There are genetic predispositions, of course, but smoking, diabetes, high blood pressure, obesity, all of those things will increase your risk of having blood vessel disorders. And it can be a blood vessel in your heart, and it can be a blood vessel in your brain that is abnormal for those reasons. So, in terms of brain health, the brain is a vascular organ, and all the things that are good for the heart are also good for the brain. So I recommend you exercise as much as possible. You stay relatively thin, you eat a healthy diet, you get a good night's sleep, you don't drink alcohol. All of those things will be good for your brain.
Ooh, what do you eat? Are you a vegan?
I am not a vegan.
Me neither.
I do try to eat a fair amount of vegetable protein just because I don't like whey. But I'm not uniquely a vegan, but I try to eat a healthy serving of vegetables and not too much red meat in my diet. But aneurysms are a fascinating disease because, I talk about, first of all, I give the story of Joe Biden, which is very timely.
Oh, yeah.
Not everyone knows that he had 2 craniotomies to treat his aneurysms. He had 2 aneurysms back in the 70s. And 2 neurosurgeons opened up his head and they treated one that ruptured and then treated a second one. And a lot of people wonder, does that explain, what we've seen in the last couple of years with his cognitive decline? And the truth is it may, but it doesn't necessarily explain it. We know that an aneurysm can rupture and reveals basically blood surrounds the whole brain. It's called a subarachnoid hemorrhage. And that can be very damaging to the brain. 50% of people who have an aneurysmal rupture will ultimately die of that. So it is very dangerous, but people can make a complete full recovery. He was probably cognitively impaired for a couple months after his surgery, but some people will get all better, and just doing neurosurgery in and of itself doesn't explain his cognitive decline in recent years. But we now no longer open up the head to treat most aneurysms. We actually treat them using what's called interventional neuroradiology, which is another modern technique that was developed, in the 1990s and was initially not well accepted by the neurosurgical powers that be, where we can put a catheter in through an artery accessed in the wrist or in the groin, thread it up inside the aneurysm, and just unload a couple of metal coils and coil them up in the aneurysm, make it clot, and treat it without ever opening up the head. So now some 80% of aneurysms are treated using a technique that didn't even exist when I trained in neurosurgery. So that's remarkable progress. And the same is true. Yeah, the same is true of stroke, by the way. And I tell stories of one of my friend's moms who, came into the emergency room, had a stroke. One of my partners took care of her, and we now have the ability to thread a catheter up just like we would use to treat an aneurysm and basically suck out the clot that's causing a stroke. You get a stroke because you get a little blood clot that blocks off an artery going into the brain, so the oxygen, the blood flow can't go in there. And we now have the ability to reverse that, which is really revolutionary because we had no way to treat stroke for decades until, again, around the early 2000s when these techniques were developed.
So timing is everything on there. Get to the OR as fast as possible.
Yeah. You have a couple hours to get it done before it's irreversible.
Yeah. Amazing. By the way, when you go up through the nose, do you do that because the bone is thinner up in there versus going in from the top down?
Well, we go up through the nose because the tumor is underneath the brain, right? If you go in through the top, you have to go through the whole brain to get to the bottom of the brain. If you go in through the side, you have to dismantle the whole side of the head and then go under the brain. The most direct way to get to many tumors would be up through the nose. It's just we had no way to close the hole that we would make. And the nose is not sterile. There's bacteria teeming in your nose. And the idea of going through an unsterile cavity into the center of the brain was so counterintuitive to neurosurgeons who try to do everything completely sterilely that they just couldn't imagine that that could be done safely. And for some reason, it can be. And I think it's because we give strong antibiotics before they do the operations. And we now have developed ways to close the top of the nose, that communication between the nose and the brain, watertight. So now we can safely do these operations and get right into the bottom of the tumors. And it's remarkable because you see the patient the next day, you don't even know they had surgery because the whole surgery, they have a little Band-Aid under their nose, and we went into the center of the brain to take out a tumor. So
Unbelievable.
I love doing those operations because I know that I never learned how to do this, and that there are not a lot of people. Now there are more and more people in the world, but there was a period of time when I was one of like 5 or 10 people in the world who had the ability to go up the nose and take out a tumor in the center of the brain. And you really feel like you've, contributed something to the world. You've moved the field forward in a way that's really tangible. So those are some of my favorite operations.
Unbelievable. That's just amazing. And that's so new. Again, it's like this is just decades old or years old, I guess, in that case.
I think the first one was done about 20 years ago.
Unbelievable. Okay, I know you've been generous with your time here, but just a couple other things on how much we've learned about the brain for when it goes wrong. So here you talk about Henry Moyleson, famous HM, and Phineas Gage. All of Oliver Sacks' chapters and books are about people whose brains go wrong, and from that we learned X. That's so interesting. So talk about those two cases and what we learned from that.
Yeah, the Phineas Gage case I don't talk too much about. It's sort of an introduction to the frontal lobes and how important they were. But yes, it was one of the most classic historical cases. And I went to Harvard Medical School, and it turns out there's the Warren Anatomic Library, which is in the museum, which is in the Francis Countway Library, which is the library of the med school. So when I would go to study between classes, I would go to this library, and you walk down a hallway, and there's a little museum tucked away at Harvard Med School, and in there is the skull of Phineas Gage. So I was very influenced by seeing it and reading the story. So it meant a lot to me, and in my upbringing. But that's a classic story where he's tamping down and working on the railroad, and he's working with explosives, and he's got this long metal javelin that he's hammering in, using a hammer, and it explodes accidentally, and it gets shot up through the bottom of his face, through his skull, blows the top of his skull out, basically wipes out his frontal lobes. He somehow survives this horrible accident, but it completely changes his personality. He transitions from becoming this very fastidious, careful, thoughtful individual to sort of this wanton, crazy, unhinged person, and it completely alters who he is. And his doctors and friends said he's no longer Gage, which, by the way, speaks a lot to personality. And it's the whole idea that who we are and who we think we are can be altered on a dime based on changing our brain. And so we really are not so stable as individuals. And the concept that the self is somehow this unchanging thing out there in the world that floats around that controls our bodies is just ridiculous, because I can change it in a second. But the HM story is really a fascinating story, and it also overlaps with neurosurgery, which is why I tell it, right? So the book I wrote is not a book of neurology. It's a book about neurosurgery. So all the cases I'm telling are specifically related to neurosurgeons. So there was a neurosurgeon named William Scoville, who worked at Hartford Hospital. And he was a bit of a maverick. He liked to drive fast cars. He was a cowboy. He was a very well-respected spine surgeon, and he liked to do frontal lobotomies. And he had developed a new way to do a frontal lobotomy by going underneath the frontal lobes as opposed to going down from the top of the head. And he realized when he did his frontal lobotomy, he could actually see these two structures called the amygdala and the hippocampus. And at the same time, Wilder Penfield was up in Montreal and had just discovered that when you remove the amygdala and hippocampus, you can treat most forms of epilepsy, particularly those that come from the temporal lobe. So Scoville was familiar with what Penfield was doing, but Penfield only took out one hippocampus. And he only did it if he put electrodes on the hippocampus and found abnormal discharges. Scoville did this experimental operation on his patient, Henry Moyleson, who came in with seizures. And he decided, well, if it works on one side when Penfield does it, let's do it on both sides. It'll work even better. So he goes in and takes out both of Henry's hippocampi and amygdala. And Henry wakes up and loses the ability to consolidate any sort of memory. He can't form new memories, so he just lives in the present. So if you meet Henry, he will be perfectly pleasant. He'll talk to you. He'll get to know you. And if you walk out of the room and come back in, 5 minutes later, he'll have no idea who you are and will forget having met you. And Henry was studied for the next 40 years by neuropsychologists, one in particular, a very famous neuropsychologist named Brenda Milner, who worked with Penfield, who came down. Scoville, to his credit, called her and said, you need to come down here because what's going on here is unusual. And we learned at that moment that there are different types of memories. They're stored in different parts of the brain. Henry could learn how to do things, activities. We know that those manual behaviors are stored in the cerebellum, a different part of the brain, as opposed to facts about history that are stored in the hippocampus. And so neurosurgeons, and this unfortunately Scoville, by accident, taught us an enormous amount about memory in the same way that Joe Bogan's split brain experiments taught Mike Gazzaniga and all of us about the different lobes of the brain. So I'm trying to reintroduce neurosurgery into these conversations and show how critically important neurosurgeons have been over the years in teaching us about the brain, because we're the ones who can alter the brain. We're the ones who can actually do the hands-on experiments, as opposed to philosophers who are sitting in an armchair, or neurologists like Oliver Sacks that are waiting for nature to harm the brain so they can learn something, right? We don't have to wait. We can go in, we can stimulate the brain, we can put electrodes in the brain, we can do things and do real experiments on human beings to learn how the brain works. And that's how, I talk about other neurosurgeons who've done experiments in memory where they were recording from the hippocampus and from the brain at the same time to show that the way that the brain moves memories from the hippocampus into the brain to long-term storage is that the neurons are literally firing at the same frequency in the same pattern in these two different areas of the brain. And you can record that with electrodes to learn how the brain does those particular consolidation of memory. So it's remarkable how much neurosurgeons have contributed to our understanding of the mind. And I really wanted to emphasize that in the book.
Yeah, it's like those experiments with patients that are going under surgery for epilepsy and so on. And while they're there, they wake them up and then tap around to ask them what's going on. There was that woman, who was the neuroscientist? Olaf, I forget his name now. But he touched different parts of the temporal lobe, and the female patient has an out-of-body experience. She goes, I'm up by the ceiling now. And now my left leg is floating. Now my right leg, left arm. He's just tapping around like the map of, Wilder Penfield's map of the, and just tapping around there. To me, that indicates, well, a near-death experience, out-of-body experiences, nothing's leaving the brain. You're just stimulating different parts of the brain to produce that experience of floating and flying and leaving or whatever.
And if you think about a near-death experience that people have, where they see a light at the end of the tunnel, people who are at the verge of dying and then come back, you could imagine that the brain is firing off all different kinds of chemicals. These people are in ICUs. They're incredibly sick. The blood flow to their brain is, diminishing as they're approaching death before they're brought back. And that's going to change the biochemistry of the brain and the firing of their neurons. So they're going to experience something that it is like to have your brain go through that state. It doesn't mean that those things are real and that they exist, because everything we experience just happens in the brain, whether it's real in the outside world or not. It's an illusion. It's a movie that we make about what we think is going on.
Yeah, it's like that physician for the U.S. Air Force, James Winery, who accelerated pilots in a centrifuge until they black out part of their training. But a significant percentage of them had an out-of-body experience, and they saw the kind of tunneling. I guess that would just be oxygen deprivation to the retina or something, or maybe to the occipital lobe.
Yep. Yeah, it makes sense. Very consistent.
Yeah, amazing. All right, you mentioned your father's stroke and death toward the end of your book. You want to say a few things about that?
A little bit. It reminded me of the story you told me of your mom when you got on the phone in the psychiatrist's office and ordered a test got a referral to a neurologist by, saying you were a doctor. So I had a very similar experience, right? I was my dad had a surgery in a hospital where I did not have privileges. I worked at Cornell. He was at Mount Sinai. He had a duodenal tumor removed. So a very simple operation in his abdomen. And I was in bed and my phone rang, and I picked up the phone, and my father was on the other line. But the only way I knew it was my father was because I recognized his voice, but he couldn't speak. He was trying to talk, but he just couldn't get the words out. And I had recognized that kind of speech. I think I was a 6th-year neurosurgery resident at the time. I've obviously taken care of a lot of patients. I've seen patients in extremis. who had Broca's aphasias, which is what he had, and it's a type of brain damage that gives you trouble with at the output of speech. So I immediately, got dressed. I ran into the hospital. I went to his bedside, and sure enough, he couldn't talk. And he looked very upset. He was very frustrated. He knew that he couldn't talk, which is why he had called me. And I went to the nurses and I said, my dad needs a neurology consult right now. He needs a CAT scan. And they got a neurologist on the phone, and I convinced the neurologist to order a CAT scan because I was worried that he had had a stroke. And I went to the nurses and I said, okay, the CAT scan order is in. Let's go. And the nurse said, well, we have to wait for transport. And that's how hospitals work. And I'm very aware of that, there's someone whose function it is to transport patients to their tests. But in neurosurgery and in our residency, we learned if something needs to be done right away, you do it yourself. You don't wait for anyone else to do it. And I said to the nurses, where's CAT scan? They said, oh, it's on the 5th floor. So I went into my dad's room and I took down his IVs and I packed him away in the bed, which I had done countless times as a resident. And I wheeled him past, grabbed his chart off the chart rack and said, I'm going to 5th floor. And the nurse, I remember, was screaming at me saying, you can't do that. And by the time she said it, I was already in the elevator. So we show up at the 5th floor. I'm looking at the signs, where's CAT scan? I wheel him down to the CAT scanner. I go to the tech who's there. It's a Saturday. I said, I'm Dr. Schwartz. This is my patient, and he needs a CAT scan. And the order was in. I moved my dad onto the stretcher. And obviously it's a fun story to tell up until that moment. But then, I'm sitting in the control room, and in the control room where the tech's doing the test, you can see the images coming up one slice at a time. And if I tell you, Mike, it was just so uncanny to see my father's brain slice by slice coming up in front of me, and knowing, in my heart, anticipating and fearing that I was going to see a big black hole, which is what a stroke looks like on a CAT scan. The brain has died in that area. And sure enough, there it was. The slice came up, and to make that diagnosis on my dad was horrible, and something I'll never forget.
Yeah.
And he died, a few weeks later, unfortunately. And I also write about in the book, one of my regrets, of course, was that because I was becoming a doctor, I was taking on the persona of a doctor, and I tried to remain very stoic and optimistic for him. We're going to beat this, Dad. I'm going to take care of you. And never really had the chance to have that heart to heart with him and tell him what he meant to me.
Oh gosh. Oh, I'm sorry. Yeah, that's rough. When I read that part of your book, I pictured that scene from The Godfather. Michael Corleone's moving the bed with the Godfather in it.
Yes. It's funny. I just reread it when the guys are trying to assassinate him, right? He's trying to move him out of the bed so he doesn't get shot. Yeah, it's a great scene.
Yeah. All right, last personal story. So when I was right out of college, my college sweetheart, Maureen, got in a car accident and broke her back and paralyzed, paraplegic, and she still is. And so I read about all the Cure Paralysis Foundation, all these different nonprofits and the research and this and that. And I thought, well, by, the end of the century, we'll have a cure for this. Why can't they rewire the spinal cord around the injured part? There's all these kind of sci-fi scenarios, but seems like we're still a long ways from fixing paralyzed
So we're
people.
getting closer than you think. The hard part is that neurons, when they're transected, don't always just grow back. There is some neuronal regeneration, but it's not so easy to coax a neuron to grow, and it's got to grow. You can't just jump wire it, because all the neurons past where the transection in the spinal cord is will ultimately die. So you have to figure out a way to kind of get it to go much farther than that. So one thing that people are trying to put stem cells, into that area to try to get regrowth, and there has been some success in doing that. But another possibility is coming to the forefront, which is to take a brain-computer interface. So you can implant wires into the part of the brain that moves the arm or moves the leg, if you will, in this situation. And then take another set of wires that activate the muscles of the leg. And have a computer basically take the brain waves out of the brain that want to move each of the different muscle groups and translate that, send it. You can use Bluetooth. It's not, magic technology, to the activating electrodes in the patient's own muscles to reactivate them electronically, because muscles respond to electrical currents. If you stimulate a muscle, it's going to jump. And so it's possible to create a sort of brain-computer interface jump graft electronically to reanimate muscles, and maybe even reanimate some of the nerves going into the muscles if you can do it early enough and keep them alive. So I think there's going to be more progress on that going forward. Another thing you could actually more easily do is if you took someone who is paralyzed and you created an exoskeleton around their legs, a robotic exoskeleton that allowed them, if it were controlled, to stand up and move, you could put a brain-computer interface into their brain and it would control the exoskeleton so they could just get up and the exoskeleton would move their legs and they could move around again. So I think there's more coming. The hard part is biologically reinnervating those neurons and getting them to regrow. That's been more challenging than we thought. So the answer may be to use electricity.
Yeah, right. Okay, last question on the future. Are you optimistic about companies like Neuralink and the others, and that the future, I don't know, 50 years from now, 100 years from now, we won't need people like you? Wait, you have an epigram here from your man, Cushing. I would like to see the day when somebody would be appointed surgeon somewhere who had no hands, for the operative part is the least part of the work.
Yeah.
Great
so
quote.
I'm very optimistic. First of all, I think Elon Musk has created an incredible little device with the Neuralink. Creating an electronic car, you're taking all existing technology. We have the ability to make an electronic car. He just did it really well and marketed it. He has created a new type of brain-computer interface. The ones that we've used traditionally are what's called the Utah array, which is basically 100 tiny electrodes that look like little spikes that are basically banged into the brain, or grids of electrodes that we put on the surface of the brain. And he created a robot that basically threads in a lot of tiny threads to avoid the blood vessels, to try to do it in an atraumatic way. And then put it in the skull, the actual computer, and then wirelessly send that information to control a computer. It actually moved the field forward. It wasn't just taking existing technology. He actually tried to innovate a little bit in creating this device. And it's working remarkably well, not surprisingly, because we knew all the things that he's doing with his BCI, we've already been able to do with other types of BCIs, either the Utah array. I actually consult for a company, Layer 7 Precision Therapeutics, that makes a different type of brain-computer interface, which is basically a postage stamp of 1,000 electrodes that's very, very thin, that you can put in with a minimally invasive surgery and just lay it over the top of the brain. So it uses an alternate strategy from Elon Musk's strategy. But now that there's a couple different companies that are both competing to create commercial devices that will go out into the public, I think things are going to move very, very quickly at this point. And the second patient was already implanted by Elon. We haven't gotten all the results as to how he's doing, but I actually just checked the blog today. They have a blog every day, Neuralink, and I'll actually check it once a week and see what's going on, because it's so exciting. Showing that the speed with which he was able to control a computer, it was like in a day. Like the day after surgery, with just his thoughts, he was able to move a cursor on a computer screen, which is really remarkable. Which brings us back to the self, right? So if I can, the things that I can move with my thoughts are part of me. They're who I am, right? I can move my hand so it feels like my hand. I can move my leg, it feels like my leg. It's part of myself. When I can think and move a cursor on a computer screen, well, I feel like that cursor is part of me, part of my body. My guess is that they will. These people haven't been around long enough, but I think that the idea of the self is going to be extended into computers and objects once we can harness the power of these brain-computer interfaces. What's much more difficult is getting information into the brain. And that's a distinction I draw in my book. We're all excited in what we can do, and it's easy to get information out of the brain, mostly motor information, including speech, because we can articulate, we move our mouths and our tongues when we speak, and we can take that information out and turn that into words. But it is very hard to get information into the brain. And so these visual prosthetics that we're trying to create right now, they work based on something that Penfield discovered years ago, and some other surgeons before him, which was, if you stimulate the visual cortex, you can create just flashes of light. And everywhere you stimulate will create a little dot flash of light in a different location. And so it's possible to create a device, and these have been created in the past, that take a video camera on someone's glasses, put it into a computer, and that computer will control the stimulation on the brain, and they can create outlines of what the video camera sees based on flashes of light. So it'll kind of look like a jumbotron or like fireworks, displaying an object. It's not going to look like vision as we know it. It'll look a little bit different. But that technology already exists, and there are companies out there making those kinds of devices.
So amazing. Arthur C. Clarke's third law: any sufficiently advanced technology is indistinguishable from magic. That's great. All right, Theodore, thank you so much for your time. Here it is, Gray Matters, a biography of brain surgery. Get it. It's a great read, or just get the audio edition. And it's just a gripping, really good book, really well written. Okay, so there's your next book, The Future of the Brain. That's your sequel.
Love it. You'll be my co-author.
Oh, no. I just like to read them. I don't know what I'm talking about. All right, Theodore, thank you so much for your time.
My pleasure.